Hello from the Colorado School of Public Health to our instruction team and our colleagues in class. Welcome to our group project. Our topic is translating innovative approaches. Our method was PrEP in Kenya, and our team is Cecilia, Amelia, Amanda, James, and myself. I'd like to start off today with a quick outline of approach. We're going to talk about Kenya's demographics, health statistics, talk about Kenya in a bigger context, talk about the actual translational science of the PrEP, the success and limitations, and then end with some discussion questions. Country information on Kenya. It is in Africa, bisected by the equator. Kenya borders Ethiopia, South Sudan, Uganda, Tanzania, and two bodies of water, the Indian Ocean to the east and Lake Victoria on the west. Capital of Kenya is Nairobi, and they speak Swahili and English, and their currency is the Kenyan shilling. The country demographics of religion in Kenya is approximately 83% Christian, about 11% Muslim, and the graph on the right-hand side depicts the difference between the males and the females in the population. Population in 2019 was almost 53 million people in Kenya and grows at a rate of 2.6% annually. The life expectancy from birth in Kenya is almost 63 years. The proportion of the population living below the extreme poverty level is 37%. Approximately 23% of the population is suffering from hunger, and the country suffers from moderate severe food insecurity at 56.5%. The basic sanitation services is on the decline. In 2000, it was 33%, and road went down to 29% in 2017. The topography of Kenya is only 20% suitable for cultivation agriculture, and that's the most important economic activity in the country.
All right, and then we will go straight into the health status of Kenya. Some of the main health challenges that Kenya faces today include high maternal and child mortality and high burden of infectious diseases, including HIV, tuberculosis, and malaria. The maternal mortality ratio is 211 per 100,000 births, but has been generally declining at around 2.9% per year. The high burden of infectious diseases can be attributed to environmental and geographic variables, which will be discussed later in our presentation. HIV is the leading cause of death in Kenya, and there are several factors involved. About 31% of tuberculosis patients are actually HIV positive as well. There are about 6.7 million new cases of malaria every year. And in Kenya, financing of these types of communicable and non-communicable diseases is dependent on donor funds from international organizations like USAID and help from other nations. There are several unique regions within Kenya that have different health outcomes due to the environment and geographic features. Within the coastal regions, there is a high rate of black flies, mosquitoes, and mangrove flies, which can attribute to the high rates of malaria infections as discussed earlier, and diarrheal diseases. In northern Kenya is where sandflies live, causing parasitic diseases, which also attribute to diarrheal deaths. In the Lamui Valley in the Samaya area, CC flies cause sleeping sickness. And in the south of Kenya is where most of the population lives, and nearly all of the economic production is centered. This large influx in population can be in part due to the lack of healthcare services and longer wait times to see a medical provider. The climate in the north and east are mostly arid. Nairobi, the capital, has 4 seasons, which is mostly moderate temperature near the equator. Kenya's average temperature has been increasing, however, throughout the years. The government has acknowledged the impact of climate change on people's lives. However, there have been some national policies created to address the effects of climate change, but these existing policies largely fail to address the disproportionate impact on Kenya's most marginalized populations, including Indigenous people, disabled women, and children as well. Regarding the environmental status in Kenya, some of the main issues that this country faces include water pollution in urban and industrial areas, decreased water quality due to the use of pesticides and fertilizers, and the others listed along this slide. Kenya's healthcare system contains private, public, and faith-based or NGO systems. Kenya's the pilot launch of the universal healthcare system in 2018 faced several obstacles. It only reached about 0.5% of the population. The challenges that they faced included a lack of transparency, access to facilities that accepted national insurance, and medications were not always available, causing patients to run over to private pharmacies, which have been historically corrupted. The National Hospital Insurance Fund, NHIF, was established in 2014, which offered access to cheaper healthcare as a form of government subsidized healthcare plan. The main elements of NHIF were in line with the WHO healthcare coverage goals. However, it did struggle to cater the growing population in Kenya. So only about 11% of Kenya's population is covered by the NHIF, leaving 89% uninsured. They have also faced numerous reports of corruption that have not been typically carried out by government intervention. The capital of Kenya is Nairobi, as discussed earlier. It did win its independence from British colonial rule in 1963. So the political system in Kenya is a unitary state comprised of a multi-party system. It is a political organization where most or all of the governing power resides in a centralized government like Northern Ireland and Great Britain. Overall, there is a general distrust in the government due to high levels of bribery and mismanagement of terrorism in the country on several occasions, especially during mass genocides that have occurred in Kenya. It is a lower middle income country. The GDP per capita is $1,838, and the poverty head count is around 37%. There is a large gap between the rich and the poor. About 70% of families are chronically vulnerable due to poor nutrition, food insecurity, and preventable diseases. So many Kenyans suffer from economic inequality while the elite continues to exploit labor, resources, and other opportunities.
Looking at a broader picture, there's societal stigma and governmental distrust have been major contributors to the HIV epidemic in Kenya. Stigma has been prevalent since the beginning. The earliest known cases were discovered as early as 1983. However, due to the fear of a negative economic impact, Kenya's government didn't act. This inaction led to the epidemic status in the late 90s and resulted in devastating mortality, morbidity, and social consequences. Stigma is one of the leading reasons for why HIV is so high in Kenya, to the point that it is the leading cause of death. Kenya, in combination with Mozambique and Uganda, has the third largest epidemic of HIV/AIDS in the world. The population most at risk for HIV are men that have sex with men, women, sex workers, and drug users who use injection. And sex workers have the highest prevalence of the at-risk group. In 2011, it was estimated that 29.3% of sex workers have HIV. This is so much higher because sex work is illegal and they get no protection from law enforcement. Those already with HIV would be at risk for detainment, which would impact their ability to access treatment as well. One positive is that once a positive HIV test is received, sex workers are one of the most intervening groups combating HIV spread. About 92% will use condoms, and about 79.7% of sex workers aware of their HIV status will seek out PrEP treatment. In 2010, it was estimated that 18.2% of men that have sex with men have HIV as well. In Kenya, it is illegal to be homosexual, and it can even result in a prison sentence of 14 years. The political climate around this issue is one of the leading reasons why men who have sex with men don't obtain treatment. Although this has improved in recent years due to the efforts made by LGBT communities, there is still a lot of stigma and abuse that makes it difficult to obtain appropriate care. Similarly, drug users who inject themselves often don't obtain treatment due to the illegality of their choices and are unlikely to seek treatment or receive support as well. Have the government to destigmatize HIV, so harsh discrimination that prevents people from accessing HIV treatments. A research study from 2014 shows that 44% of female sex workers, 24% of men who have sex with men, and 57% of people who inject drugs were arrested or beaten up by police or city vigilantes within 6 months of the study. In 2016, 910,000 women had HIV in Kenya. This makes up 56.9% of the total population living with HIV. Women in this country are much more prone to HIV due to the inequality with education, access to healthcare, employment, and sexual violence. Women's low income and social status limits their power to negotiate the use of condoms, discuss infidelity with their partners, or leave risky relationships. Such disempowerment, it increases their vulnerability to HIV. There was also an economic shift that occurred that had a significant impact on their ability to coordinate effectively on HIV programs. Kenya was initially classified as a low-income country. This low-income status led to 75% of their funds for HIV treatments and education programs to be externally supported. However, after 2015, Kenya moved to a lower middle income status and has since seen a drop off from their external funders who tend to focus exclusively on low income countries.
Now we're going to talk about the method, and ours is translating innovative approaches or taking innovation to scale. What this is translating research evidence to reduce health disparities by conducting research, generating relevant evidence, and translating research findings into evidence-based guides. There are a few models for taking innovation to scale, and these include re-aim and translation and dissemination. These efforts refocus on research that is contextual, practical, and robust, and move public health towards sustained intervention effects at both the individual and community levels, which includes community-based participatory research, which creates a dialogue between the researcher and public health workers and the community. But when interventions are scaled up, some of the benefits may accrue unequally across different socioeconomic positions and exacerbate disparities. So translation and dissemination is the effective dissemination of evidence-based programs in a time-efficient and manner with ongoing training, and which continue to highly value research-informed practice. This is a multi-step process, and the first step is to discover the determinants of health and develop and test scientific methods and theoretical perspectives. The second step is to synthesize research findings and translate them to target populations, consider the context of the conditions in which its members live and interact. This must consider cultural adaptation of the innovation to match the innovation to the target's needs. In this step, you determine the relative and differential advantages of the innovation. Relative advantage is the first level of success, like a positive health outcome or cost savings, and differential advantage is the extent to which an innovation interacts with other interventions to improve outcomes on a larger scale. Step 3 is to communicate translated research to the population in a meaningful and relevant way. This communication needs to be culturally adaptive and active dissemination of relevant communication to come across properly. The goal of this is the long-term objective is the institutionalization and maintenance of the innovation into the routine practices of a social system, which requires the consideration of cost, modifiability, and the organizational support for the innovation. The final step is to improve long-term change through program adoption, policy change, environmental change, and behavior change, with the ultimate goal of improving health indicators and quality of life. One of the limitations, though, is that for preventative interventions, relative advantage is sometimes difficult to quantify because there may be a delay between adoption of the innovation and when success is realized. So our implementation is PrEP, and why this is needed is because scaling up is a key element to countering the HIV/AIDS epidemic worldwide. It requires everyone to move beyond pilot projects and establish specific and time-limited targets to accelerate the momentum for expanding treatment, access, and adherence support. And one of these specific and time-limited targets is the 90-90-90 goals, which we've learned about in this class. And Kenya really needs this because there's 105 million people living with HIV and 400,000 were unaware of their HIV positive status. And those that are unaware are untested and go untreated, which continues to spread the disease. So what is PrEP? PrEP stands for pre-exposure prophylaxis. It's an antiretroviral therapy used as prevention for those who are HIV negative and who are at high risk of HIV infection. Amanda already pointed out those key target or most at-risk populations in Kenya. There have been several trials to use and test PrEP in Kenya and other countries in sub-Saharan Africa, and it is highly effective when it's used properly, which is one of the limitations, is that high adherence to the regimen is essential to achieve the clinical benefit. So how has Kenya used PrEP or innovation to scale for PrEP? In 2012, the US FDA approved Truvada for PrEP use, and in 2015, it released its recommendations for global implementation. In 2016, Kenya released their National AIDS and STI Control Program, or NASCOP, which includes PrEP as part of their antiretroviral therapy for treatment and prevention of HIV. In the same year, the Kenya Pharmacy and Poisons Board approved and made Truvada available for adults at high risk of sexually acquired HIV infection. And then in that same year, they formed the National PrEP Technical Working Group, which guides and implements planning and ongoing learning for PrEP scale-up under 6 subcommittees, which are the Communications, Advocacy, and Community Engagement, Strategic Information, Research and Implementation Science, Commodity Security, Service Delivery, Costing, and Resource Mobilization. By the end of 2017, the PrEP TWG had conducted stakeholder engagement meetings, healthcare provider training, and county readiness assessments, and had finalized the implementation framework and begun their marketing campaign, which is GPENDE GPrEP, and that's a poster for their campaign. Kenya is sustaining and adjusting the PrEP program over time through efforts primarily led by the government through the Ministry of Health, which is funding with funding and structure from DREAMS, USAID, and the Bill and Melinda Gates Foundation, among other sources. Gelende is the key program, and it's the national scale-up and evaluation of the scale-up, which are both ongoing. It's structured and funded by the Bill and Melinda Gates Foundation under the Development Evaluation Approach, which is a translation approach, which supports continuous adaptation in complex environments, as Kenya is. The goal of Gelende is to seek the best way to implement oral PrEP services while retaining the highest risk people at scale and in the most cost-effective manner and at scale. They seek to answer the questions of like what changes may make PrEP more acceptable and easy to use, what barriers are emerging and what is the best way to minimize them, how is PrEP perceived within the community over time, and what interventions improve that perception. As I mentioned, there are several programs going on. The GPENDE GPrEP, Love Yourself, PrEP Yourself is their media and resource campaign. They're trying to get people to recognize the need for PrEP and then go to their website to access the resources for it. The Be Self-Sure campaign is 2-pronged, where they send out self-testing HIV kits. And then for those that test negative for HIV, they try to promote them to take PrEP. And then DREAMS is specifically focusing on women and girls, and it's a multi-focused self-efficacy campaign that not only promotes PrEP, but also education and employment. This is one of the media campaigns that you can check out. These are the self-testing options that are sent through the Be Self-Sure campaign. These are several projects that Kenya has implemented for their PrEP scale-up, and there's only a few listed here, but you can click on the links for more.
All right, and I'm going to talk to you about some of the successes and limitations of these implementations. So PEPFAR is the US President's Emergency Plan for AIDS Relief, and this is actually the largest commitment by any nation in history to target a single disease. And their target for Kenyans that were on PrEP for 2021 was right around 100,000. And actually, as of July 2021, there's an estimated 111 to 112,000 PrEP users in Kenya. So they have surpassed the target, which was something to celebrate. Some general progress that we've seen, some costing studies have helped inform delivery. Oral PrEP is now available to all persons that are considered to be at substantial risk throughout Kenya. This includes all 47 of their counties. There are options for preferred and alternative regimens that are now being offered to these patients that are at substantial risk. And additionally, we've seen an increased prevalence of risk assessment tools to help identify these potential patients who may be at risk for HIV. As was mentioned earlier, adherence can be a challenge for PrEP, and it's very important. So adherence counseling and peer education efforts have been increasing in the past decades as well. Here we have an image just showing that about 90% of Kenyans are aware of their HIV status, of which about 82% are currently on treatment. And of these, about 92% are getting the full viral suppression. A couple of the limitations to implementing PrEP solutions within Kenya, as was mentioned, the importance of adherence can be quite challenging. It is required to be taken essentially as prescribed to decrease the transmission rates. Additionally, it can be difficult to raise awareness and promote community buy-in. Often it can be difficult to provide evidence to populations who may lack formal high-level education in some of these communities. Additionally, as has been discussed briefly earlier in this presentation, the stigma surrounding HIV and AIDS and the prevalence of HIV in sex workers is also a significant challenge. And when talking about scaling up these PrEP initiatives, there are a few challenges that I'd like to bring to your attention as well. So with the growing population, there is a greater need for the resources that are available. And this kind of causes the initiative to focus on populations at greatest risk and really leads us to a point where we need to have campaigns that are focusing on targeting continuous use of PrEP so that patients who are initiated on it are taking it throughout their lifetime. Additionally, it can be challenging to forecast the demand. So that brings to light some supply chain management issues. Also, it can be difficult to determine the source of the medications, as Kenya does not have any domestic financing provided for these PrEP initiatives at this time. Additionally, promoting uptake is incredibly important, mainly due to the stigma that still remains in Kenya. So this is primarily done through marketing, addressing the social stigma directly. And as I mentioned, we'll need to kind of move forward to some campaigns that are looking at continuous use and not just within the first month that they're prescribed. And then additionally, it can be difficult to monitor and evaluate these processes so that to ensure sustainability.
I hope that you've seen that our team is encouraged by the progress made in Kenya with this methodology and innovation. We believe it can scale, even with the challenges that we've outlined. We'd like to thank you for your time and attention today. Following the presentation, you'll find discussion questions and references. But thank you very much and have a great day.